Good. Well, welcome everybody. The last time we did this was 3 years ago at the Sheraton Hilton, or the Sheraton and Toronto Airport, and Dr. Ezzat was there, and we had lots of fun on the panel. And when I look back, I think I can recall that one of the themes that came up was, better communication between the different disciplines, between the ENTs, the dentists, the GPs, the endocrinologists, the cardiologists, and that was 3 years ago, and we had 2.5 years of a pandemic in there. So what has happened over the last 2.5 years in regards to communication and acromegaly treatment? That was good, that was bad over the last period due to the pandemic. Is there sort of a micro update that the specialists on the panel can give us in regards to that?
I'll start maybe from the Vancouver perspective. That I think you're right, Peter, that it's been challenging because of the pandemic, sort of one step forward, two steps backwards almost. But I know that we have a Canadian symposium coming up that I'm chairing where endocrinologists will be, like community endocrinologists and trainees will be involved, and we're specifically trying to target a little bit some of these challenging comorbidities that affect quality of life. And for example, there's going to be a 1-hour osteoarthritis sort of session where we have the rheumatologist present for 15 minutes and then some questions, and then the pain specialist present, and then an orthopedic physician present. And I think what someone like myself hopes is, like, luckily too, the speakers are from Vancouver, and then I have more of a relationship with them, and then we can know who are kind of go-to people to refer to and liaise with. So I think even though not a ton has happened, it's really on the forefront for me of one of the most important things to just sort of have one of my colleagues in Ontario used the word a champion, like sort of like a go-to cardiologist, a go-to gastroenterologist. And it doesn't mean that all of my patients will see that person, but at least somebody who has an extra interest in acromegaly. And I think that's kind of happening across the country, that people are trying to identify which other specialists have an interest in this disease. I don't know if anyone else wants to comment.
Dr. Ezzat or Dr. Cusimano?
I can't speak for the whole country, but I know in Ontario, the reality is that the pandemic had a devastating effect for pituitary patients. They were considered benign, and everyone in this room knows it's not benign. And so there were lockdowns for having surgery, so waiting lists increased. We regularly had a clinic where we had neurosurgeon, endocrinologist, neuro-ophthalmologist meeting physically in person. That had to be stopped, and so it hasn't restarted. So I think it actually set us back quite a bit. I think there's a lot of enthusiasm in this room and with the medical professionals too and everything. But the reality is we need the patients to speak up and to speak forcefully and advocate for the community to improve the situation, because all medical procedures were delayed, and it's getting worse. So I think when someone goes blind or they're suffering with the various issues that we've had, I think the voice from the patient's going to be heard much more loudly in government than anywhere else. So I think there's a lot of positive things like Dr. Ezzat just mentioned, but I think we need to go a lot to advocacy to move this along. I think we can move towards in addressing these backlogs, like to more centers of excellence. We don't need 12 centers in one province doing complex pituitary surgery. We need to use this as an impetus to rationalize and regionalize and specialize and get people together. So I think, at least in Ontario, we need to do better. And the pandemic was devastating, but there's hope there to improve it and to use that experience to move things forward.
Thank you. Dr. Ezzat?
Shireen?
My prediction is that in the next 2 or 3 years, you're going to see a huge increase in a number of many conditions that typically incubate for a lot longer. Stress is the most powerful stimulus that brings out disease, not just physical, but also emotional. What COVID has done is it has allowed for things to incubate a lot faster. Patients with everything from heart disease to Cushing's to acromegaly to every other clinical conditions you can think of is coming, and it's coming with a vengeance because patients have been cooped up. They've been restrained physically, emotionally, and have had even limited access to many things. And I think that we have to, I would argue that right now is even more of a reason for us to do a better job because these cases are going to be coming out at a faster rate. The system is not well equipped because we know that we almost always react. We never are proactive. And this is one further reason why I believe this is the right time. It's not a matter of having to cry, it's a matter of having to learn. And the fact is, I will tell you, I'm seeing worse cases coming out faster than I have ever in the last 30 years.
Wow, thank you. Dr. Ezzat, you want to jump in? There's a microphone.
Yeah, I think Dr. Ezzat just raised an important point that we all need to be aware of. Most of us, as I mentioned, we don't really know what causes pituitary tumors. We know that there are some mutations in some of them and a very few are familial, but there's a lot of evidence that pituitary disease is definitely related to life stressors. And, you know, the issue of stress inducing something like a pituitary tumor, you know, 20 years ago we would have laughed and said that's far-fetched, but I think in today's world we understand the importance of environment and epigenetic regulation of cells by things like emotional and other exogenous factors. And I think his point about a potential epidemic is actually really well made because we have all been, as a community, under stress for the last 2 years, and this is a different kind of stress than we're used to. And I think we all need to be aware that both acromegaly and Cushing's are likely to be precipitated by something like this.
Good. I think it's an important point to talk about stress. You know, I have my stresses, and my wife always says, Peter, you're stressing out too much. And then I always put it away like, yeah, maybe I do. But, you know, there's a cost to it, right? There is sort of, and I don't think we've talked enough about it over these, and I haven't not really realized it. So we got a panel of specialists and patients. So Bradley and Traci, do you want to talk a little bit about how you deal with stress? And then we'll let the specialists talk about stress mitigation.
I'll be honest, I just stress about stress. But throughout the pandemic, I think with seeing doctors virtually, I think that, if anything, created more stress because you're now trying to explain in a non-personable way the things that are going on to your body that are starting to bother you, whether it's pain coming up in your joints or more stress from just worrying about, is my health okay, is my health not? So I think just having that that bit of the less personal bit of a phone call consultation opposed to in person where you're comfortable kind of with that doctor led to a little bit more stress.
Okay, great, thank you. Traci.
Well, it's interesting when we talk about stress because I touched quite a bit about stress in my presentation, and that's not including stress prior to when my journey kind of started with acromegaly. I'm one of those people that seems to collect big stressors, so that kind of touches home for me. And so I don't really know how I deal with it other than I just do. I'm a put my head down and work kind of girl, and then things resolve. So I don't really have any good strategies to share. But for me, I think the biggest thing is just always trying to have a positive attitude, that this is the hand I was dealt, and I can be miserable as hell about it, or I can see the good in it and move forward.
Yeah.
I just want to add to this conversation, as running multiple closed Facebook sites and the pandemic and the last 2 years, Another huge stressor was those being diagnosed during COVID and being told, you have a tumor and we need to operate, but it ain't gonna happen for the next year. Let me tell you, my Facebook's lit up. People were scared and they didn't understand why they had to wait so long. So their stress levels went through the roof. So I had to explain to them, it's not that they can't do the surgery, it's because of what's going on with COVID. They've clamped down, they've made strong rules for having the surgeries that are slowing things down because we're in the middle of a pandemic. So unless you are seriously, critically in an emergency, you're not going to get your surgery until things start to calm down a bit, which helped, but didn't help. So that was a huge stressor that a person that was newly diagnosed during COVID increased their stress levels.
Yeah. So, Dr. Johnson, only sitting on the other end of the Zoom with your patients, and does the issue of stress, has that come up, or how have you dealt with it, and what sort of advice do you?
I mean, I think it's come up in person visits and on Zoom visits, but you're probably right that there's something different about the face-to-face meetings. And I think stress was there for my patients with acromegaly prior to COVID, because they're dealing with everyday stressors, plus having to deal with their joint pain or adjusting to their CPAP and all these medications and their potential side effects. And it was just like exacerbated by COVID, because everyone was feeling stressed. And I like what Bradley said. I think I kind of stress about my own stress. And there really isn't kind of a magic answer to fix it, as you guys know. And like some of it is the things that all of us should be doing. Try your best to get a healthy diet and get good sleep and try to do some exercise. And those strategies actually help people. But I think we'd like to, as endocrinologists, be able to also offer some sort of extra support psychologically to our patients. Like, it would be great if we had more access to psychologists. And, you know, I don't know about in other provinces, but British Columbia is really annoying because they don't really cover, there's no MSP coverage to meet with a psychologist. So if people have extended benefits, it might be covered. So it's harder to access those kind of resources. And I think that would have helped a lot of people in the last 2 years. And just like Deanna said, like especially the new diagnosis people that had delayed to their treatment. But on a plus note, thank goodness the acromegaly support groups existed, and that people could actually reach out to people like you and have a little bit of a, you know, calming experience that I'm talking to somebody else who's been through this, and it will happen eventually and that kind of stuff. So I guess at least you guys are a great resource.
Dr. Cusimano, do you want to add something to that?
Well, brain surgery is not stressful.
Peter, if I may.
Yeah, Dr. Ezzat, please.
So I have a word of caution that I'd like to share, and I want to know what people think about this. I'm very worried that one of the offshoots of COVID is it has allowed for complacency. Complacency in that people work out of home. Complacency is that we're going to be seeing patients virtually and not actually see them in the office. My lady yesterday actually insisted, to her credit, that she be seen physically. And I cannot tell you of how important that human interaction is. Now, I recognize very much that I'm being a hypocrite right now, because I'd rather be with you at this point, and I'm talking about, but when it comes to healthcare, if I am the patient, I would submit to all of you that your message cannot occur nearly as effectively as when you're sitting in the clinic and you are face-to-face with that physician and that nurse. And I hate to see what's going to happen if people are taking the easy way out, where there's going to be a lot more being done, especially by endocrinologists, where what they want to see is a number and a patient on the other end of a phone.
Okay, and that's a great point.
So I actually personally, I 100% agree with you. Dr. Ezzat, because I want my doctors to actually physically see me, see the changes in me, feel my skin, is it getting thicker, see if my, my color is changing in me, take my weight, and see if my bones are getting bigger by looking at my hands and feet. And you cannot do that over a phone call, right? And I just, even if it's one Zoom call a year, like, so you got 2 appointments, do one Zoom call a year and one in person a year would be still really good, right? But like, I'm also scared that our GPs are going to Zoom calls and they're going to stay on that and phone calls. And I'm scared about that because I have a rare disease. I really just want him to physically see me, so.
Okay. Well, thank you. These are great points. Heather, you have a question for...
Sorry. I might be the minority, but I kind of like the Zoom meetings as well. Like, if you have a super packed day, you don't have to get in the car, sit in traffic, drive to the appointment. And if you can see them on a screen, I guess it depends on what the appointment's for. If it's just to review your blood work and you're gonna, status quo, keep moving forward, sometimes I feel like it's less stressful to fit into my day just a quick phone call, to be honest.
Yeah. Anyone wants to respond to that?
Hang on, guys. May I respond to that point, if I could, please?
Dr. Ezzat and then Dr. Johnson. Dr. Ezzat, go ahead.
No, I'm going to let Dr. Johnson go first.
Okay.
Okay. Yeah, I think that maybe there are some things about COVID that have opened it up that in certain circumstances, maybe if somebody prefers a virtual visit, that's okay. And maybe the times that we might, especially where people sometimes appreciate it, is sometimes I'm following a patient that lives in Kelowna, for example, and that's like, a big drive, and they have to stay overnight in a hotel, and so there might be some circumstances where it makes sense, and then some circumstances where it doesn't make sense, and maybe some sort of hybrid approach is good. But I think one thing I've learned is, like, now for quite a while it's supposed to be, well, it's the patient's choice, and obviously there's times where I say, okay, it's really time that they come in, but if the patient strongly prefers Zoom, like, I try not to do too much telephone, but we do for sometimes, but Zoom versus in person, that maybe sometimes it's easier for the patients, on that day they default to doing the Zoom, but even medically, legally, that maybe we need to be more often saying, no, you don't have the choice, you have to come in, because like you said, it is kind of easier sometimes to do it from home, you don't have to park and all that, but I think now the physicians have to start going the other way and saying, no, it's not a choice. Like, my office, it's kind of a choice right now, but maybe now I have to start going, it's not a choice, you have to come in a bit more. I don't know, depending on the circumstance.
Yeah.
Sure.
Yeah, I think so too. I think it's sort of a hybrid model.
Yeah.
Looks like something that will work like once a year or twice a year, and then the rest you can do by Zoom. Because that can be done pretty quickly. Going through results is sort of a 5-10 minute job if things are stable. Anyway, I think Dr. Ezzat had one more thing, and then I'll go to Nikki. Dr. Ezzat, you had one more comment on this?
Yes, just very quickly. My warning stands. It's because of the convenience. It's because of the ease. It's because of what apparently looks like it's efficient that we have to resist that temptation. It's the heart of complacency that results in a lack of diagnosis, the delay in diagnosis. It is an evil that we must undo by trying to avoid getting into it again. I plead with you. We've lost the art of medicine because people just want to look at a number remotely, and they stop thinking, they stop contemplating, and they stop communicating. This is one step farther away from what we really want.
Okay, thank you. That's a very clear point. Dr. Cusimano, you grabbed the microphone.
Yeah, I think it's even a little bit more than just diagnosis. At least from my perspective, to operate on someone's brain, you need to develop trust. Okay? And there's a difference between seeing someone on a screen and seeing someone face to face and experiencing the emotion, the tears, the fear, and to be able to respond to that in a real way. That you can't get when the person's behind a screen or on a telephone. So it depends on the purpose of the visit, obviously. It's just you've seen the person 30 times and you already have that trust. It's just to review the results and things have been stable for the last 5 years. Sure, that may be a good way. But if I'm going in and it's complex tumor, even if it's a simple tumor, I think there's no excuse or there's no exchange for that in-person relationship. And we're going to lose that. And we're not robots. Neither the patient nor the surgeon is a robot. We both have emotion, feeling, and we need to bring that together. So I would highly encourage the patients, if they're offered Zoom call or in person, take the in-person, depending on the purpose, like Heather mentioned. But if it's the first visits or the important visits for diagnosis or treatment, advocate to get in person, okay? And I would push people to do that. And, you know, the doctors should be paid appropriately, and the patient should take advantage of that opportunity. But we shouldn't be complacent and say, oh, it's okay, the government gonna pay less money without the in-person thing, okay? But there's so much more by the in-person, and I would advocate that everybody try to do that on behalf of all the people here, all the people outside, and all the people coming in the future.
Okay, thank you. Well, I think the point has been made very clear about in-person meetings, so that's a great takeaway from this panel. Nikki, you had a question? Oh, here, JD.
Can you hear me? Yes. So I'm wondering if you in Canada have seen access to treatment by people that otherwise wouldn't be able to get it because it's either too far away, that they can access the treatment of a super specialist like a neuroendocrinologist is that something that
That's happened to me a few times with, because we service the Yukon, that's like Vancouver's their center, and I would always, people would say, can you, like pre-pandemic, can we cut to a telehealth visit? I don't want to come down. And maybe it could even be other remote areas, but I think of it especially with the Yukon, and I just had a blanket policy, like, no, I need to see people in person, especially the first time. And then when it was sort of initially at the pandemic, you know, we weren't even supposed to see people in person when we didn't know which way things were going. I think we had a lot more success with reaching some of those people. I don't even mean the people that live in Whitehorse. Like some of them are in like remote areas of the Yukon, and it's hard for them to make it to Vancouver. And they are so appreciative of the virtual option. Like, so that's the population I think we've reached more because of this. So that's kind of interesting.
I want to make a comment because now I've worked in Canada and the US, and I think that there's a really big difference in terms of access. In the US, I think it's a lot harder to get your insurance to let you get a second opinion from somebody or to be able to go to a place for treatment because of their expertise. If it's not part of your healthcare plan, they don't allow it. The nice thing about the Canadian healthcare system is that anybody in Canada can see any doctor. They can get a second opinion. They can see Dr. Johnson. They can see Dr. Ezzat, get, you know, combined opinions. There's no, nothing prevents them, and it's all paid for, except, of course, the travel. But on the other side, I want to say that having been both a physician and a patient in Canada and in the US during the pandemic, healthcare in the US went on. It stopped for like 4 weeks, and then when hospitals realized that they were losing money, they found ways to open again. And I was doing pathology on major surgeries 4 weeks after the pandemic started, while in Toronto, I wasn't getting consults forever because nobody was operating because everything was shut down. And that comes back to what Dr. Cusimano said before. You know, you classify this as a benign disease and the government says, oh, well, you don't need surgery for the next 2 years, it's just fine. Well, it's not just fine.
It's also my understanding that we are now not allowed to cross provinces. So person in BC cannot go to Alberta to see an endocrinologist. And they shut that right down. You have to stay in your own province.
I'm not aware of that. And
No,
neither
like I feel like recently I saw this nice woman from Toronto, just because all her family lives in Vancouver, and
Oh, okay, because that
vice
was,
versa. I think at the odd time, like Shireen's seen one of my patients as just kind of like a second opinion.
oh, okay.
So, but the travel's not covered. Even surgery is covered. Like you could have surgery in another province.
Oh, this is good to know.
Good.
Right?
Okay, so
There's something called the Canada Health Act that was introduced in 1984, still in effect. People are talking about making a new one. But as it is now, I get patients from BC, I get patients from the East Coast, and the surgery is covered by their own provincial system. But of course, the cost to get there is not covered unless you, like in Ontario, there's a Northern Travel Grant. And I don't know if the similar thing, I think I've treated some patients like from Prince George and things, and I think they got reimbursed for complex surgery. So I'm not sure where that's coming from, but to our knowledge, you can still cross borders, and that was enshrined in the Canada Health Act that it's portable. Yeah.
But just a thought, Deanna, maybe you're thinking about medications, because you know how annoying it is that different provinces have different coverages. And I've had patients say to me, well, you know, could we go to X province and then get it covered? But if you're not a resident with their, whatever, provincial healthcare, you won't be able to get medications. But that's not where you.
good. So there was a great discussion so far. Any other questions from the floor? People who want to talk? Mark, you're sitting next to the microphone.
Is this working?
Yeah.
So quick question. So it's kind of cool for me to see both my endocrinologists here today, one virtual and one here. So I met Dr. Ezzat 25 years ago, was my first appointment with him. And as I moved back and forth between British Columbia and Ontario, Dr. Johnson and Dr. Ezzat have traded me back and forth. But my question has nothing to do with that. Just over the past 25 years, I know the main role of healthcare is to improve quality of life. And my question is to you, over the past 25 years, has the medical advances and drugs, do you think it's greatly improving your ability to provide quality of life to your patients, or is it just kind of stagnant? Is it getting better for your patients now than it was 25 years ago?
Dr. Ezzat, you want to take that first? I think you're the veteran here. Has things improved over 25 years for patients?
I was going to say, I guess it's age before beauty, so we're going to get to Dr. Johnson to respond to that first. My response might be a little bit sort of surprising to you. I'm going to tell you something. In 1986, I was one of the so-called normal, if I could use the term normal, human subjects that participated in clinical trials where I was actually administered somatostatin analog. I was very unwell actually for a few days afterwards, and then I really had second thoughts about what I was doing. But I will tell you, when I think about it, this is 1986, okay? Like many of you in this room probably were not born, or I don't know, but the fact is, it's not the tools, Mark, that has really made the biggest difference. And in any trade, people will tell you, a mechanic, an artist, anybody else, it is the experience, it's the intellect, it's the culmination of everything that you see, think, process, and experience that come together to be able to take advantage of it to the fullest. Remember that diagram I was showing you with the red and the green? Crossing that line and straddling where you're actually doing more good and less harm. That's what we refer to as the art of medicine. And to be honest with you, the limiting factor is not the tools. The limiting factor is who's using the tools. Those are my thoughts.
Yeah, I think that's a really good point, Shireen. I would say just for the patients that are within my practice, I do think it has improved in the sense that I started in 2002 and Pegvisomant was not available. And then even when it came out later, there was nobody that we could get it covered for in British Columbia. And now, under the right circumstances, pharmacare will pay for it if we've, you know, kind of taken a stepwise approach, and people could argue we should still be able to get it earlier. But there are many people that I had inherited from Dr. Wilkins, who you guys, Shireen, will remember, who had been sort of one of my mentors, and they had had surgeries, they had had radiotherapy, they were on maximum doses of the somatostatin analogs, and they were still having elevated growth hormone and IGF-1 levels and very symptomatic, and we had nothing else to give them. And now we do have further medical therapy. And so for most patients, some people are unlucky, but most patients we can achieve pretty close to normal IGF-1s. And I completely agree with what Shireen said in his presentation, that it's not all about that number. There's lots of people that don't feel well with a normal IGF-1, and we have to just drive it. Some people feel better when it is in the low part of normal range, and we have to treat the person, not just the number. But at least the availability of medications has helped, I think, improve quality of life, because the earlier you get better control, the less complications you'll have. And I'll be interested to see what Dr. Cusimano says, that like surgical techniques have, I think, improved. You know, our surgeons routinely operate with the endoscope and tell me they get probably better visualization than they did when they used the microscope, although I'm not sure that there's any trials to say that results are better endoscope versus microscope. But in general, I think the surgeries have improved. And this reminded me of a question I was gonna bring up, that in Vancouver, like I remember when I first started, people had the story that they said the worst thing was when they took those packs out of my nose, like that was the part that was the worst. And now our surgeons are pretty routinely putting stents in, and there's no packing. And I gather that that just makes the nose heal better. And then, but I think they're still very eager to get those stents out. But perhaps like the surgical techniques have improved the healing of the nose and things like that, so quality of life.
Well, to people who are suffering, it looks like there's been no change. But I can tell you, when I started as a resident in 1985, people were getting craniotomies routinely. The diagnosis was not like the diagnosis Dr. Ezzat showed you. It was very much more rudimentary. We did not have the broad range of medication that we had. Large numbers of patients had radiation treatment, and the radiation treatment back then was a 3-portal technique, and a large number of them lost their memory over time. About 10% developed secondary tumors over time, and we had to operate on those secondary tumors. In 1993, we developed the endoscopic approach, and the big advantage was now, instead of having your eye outside the patient, it was a very simple idea I had: bring the eye inside to where the tumor is. We can turn the eye sideways, upside down, backward, and we can get to those areas. And with more knowledge about the anatomy, we started opening that cavernous sinus. So now there may be much less tumor behind. We're not perfect. We still have a long ways to go. But I can tell you that the answer to your question is definitely yes. We can tell very diagnostically much better, and the algorithm Dr. Ezzat showed you can be Dr. Ezzat showed you is very much more specific to treatment. So there have been great, great advances that have occurred over those 30 to 35 years of my experience that have been tremendous advances. Do we have a way to go? Yes, of course we do. There's a long way we still have to go, but I think definitely has gone forward. So absolutely yes is the answer to your question.
Yeah. Dr. Ezzat, do you want to add something to that? And I've got one short
Yeah, I think
follow-up
I just want to put this in perspective. I think we have seen advances in every aspect of medicine, right? And, you know, I'm thinking about what the comments have been made by all of our clinicians here. We have made advances. We have learned a lot. You know, when I look to the experience of Dr. Cusimano and Dr. Ezzat who've been doing this, they're talking about the 1980s, guys. That's a long time ago, right? Things have changed a lot. Our expectations have changed with them. Back in the 1980s, people wouldn't have complained about quality of life. I mean, think back on it. Did we do quality of life questionnaires back then? I don't think so, right? And when I compare this to other cancers, you know, we've got immunotherapy now for pancreatic cancers. People used to die within 6 months. Now they die within 4 years. They're still dying of their disease. We give them more life. We give them, you know, some improved quality of life while they're sick, but they're still dying. So I think, you know, we've made tremendous advances, but I don't want people to walk out and say, oh, great, you know, we can stop now. We can't, because the real goal is still to be able to, first of all, figure out why we get this, what are the causes, and as long as we don't know what's causing it, we can't prevent it, so we really have to look at that and try and prevent disease. And, of course, as we've said so many times today, early detection, so that we don't have to get into the cavernous sinus to try to get out what we couldn't even see before, but let's try and make the diagnosis sooner and cure it.
Yeah. Okay, can I sort of let the patients at the table, Bradley and Traci, comment on that? Like, Bradley, you know? Well, you've been in the system for 15 years, so have you seen changes, or how do you feel about it?
I mean, yeah, I've been in the system for, I guess, 15 years. But I can't, like, say I would recognize any changes, to be honest. I feel like my case has been pretty black and white, my surgery, and then it's just been kind of medication-based. There's not been anything that I would notice as far as, like, advancements.
Okay, thank you. Traci, do you have any
I'm too
observation?
new into it.
Yeah, not long enough. Okay, there was a question. Diana wanted to say something.
We talk about advancements. Where's the advancement of fine-tuning our faster quality of care for a better quality of life after surgery? We have our tumors go to the pathology to have examined. You know exactly when you look at it, right, what medication is going to work right away, right? Yes, no?
We can predict with some degree of certainty.
Yeah, you can predict what medication we need to go on right off the bat. And I mean, in Canada, we have a protocol. You need to start with this one, and this one, and this one, and this one. How come we can't change that now? We're changing everything else. Why can't we change that? Why can't we change our endocrinologist being able to put us on the right medication right off the bat to help us get to a better quality of life right now? This came into my mind like 2 years ago, and I've always wondered, can we do this? We can figure it out through the pathology, so can we get on to the medication we need to get on to right away to get to our better quality of life faster?
So let me start with, we're way ahead of the rest of the world in Canada, except for a few places in Europe, which are also, I think, in line with what's going on here. The Canadian endocrinologists are 10 steps ahead of the Americans on this one. But there are still challenges. Not every place is actually even doing the kind of pathology I talked about. So Vancouver may be getting it now, but a lot of other places across this country, you know, pathology is always in the basement of the hospital and the last place to get resource, and it takes resource to be able to do this. And you also have to have clinicians who ask the questions to get the pathologist to give them those answers. So, I mean, continued advocacy is always a good thing, but I would like Dr. Johnson to answer that, because I think she and Dr. Ezzat will tell you that they are moving in that direction, but there are still some barriers.
Yes, like what you are saying is exactly what we want to do. And it's not quite as black and white, like Dr. Ezzat said, that, oh, 100% you're not going to respond to sandostatin. You may predict that we're going to respond better to pegvisomant, but it's still may be reasonable to start the sandostatin first, but at least not be on it for 2 years before you get the next medication. And I think we've made big headway in being able to switch to the right drug quicker than we would have years ago, for sure. And I think that I really want to acknowledge and thank Dr. Ezzat and Dr. Ezzat, because this work that they've done with the World Health Organization with reclassification of the tumors and the naming them the pituitary neuroendocrine tumors, and just acknowledging how important the different pathology information is to help you guys get on the right treatments. Having this official document has helped people like me to review it with our own pathologists and say, listen, we need to be up to date with the World Health Organization recommendations, and they've really engaged on that, really because of the work that these two have done. And it's a big step forward that Canada is like a leader in that field. And you guys don't probably, well, I guess you've kind of getting the impression that these two are really like forefront of it all. I don't know, and it helps us. So I had sent an email to Shireen saying that we have this joint pituitary and pathology rounds, and we had gone through it all. And even like, I don't know, so many years ago, Dr. Ezzat came and spoke once, and after that, they started giving us the sparsely granulated and the densely granulated information, which makes a huge difference. And now our transcription profiles should be up and going within the next, I don't know, I think they said September. It's September now, so we'll see the next tumor that gets done. So lots of advancement.
Yeah, so, great.
Yeah.
So we've made lots of advances then. That is very clear. And the fact that we're sitting here today, like even 10 years ago, that would not have been possible, right? The flow of information, the data that we're gathering are phenomenal. You go with a question.
Oh, that's okay. So, you probably can hear me very well. Oh, yes, that's true. Excuse me. So we had talked briefly about removing the cavernous sinus, right, when you go back in. Is that, you said it was, sorry, Dr. Ezzat, you said it's a little dangerous, but I wanted to kind of get more information of what you guys feel, especially, I'm going to say it wrong. You. About like what you think about removing the cavernous sinus to get the rest of the tumor out, the residual tumor.
Well, not every patient has the same tumor, okay? Every patient has a different tumor, so I can't answer that question in a general way. But what I can tell you is that for many years we've been doing that. We actually presented our work again to Shireen's comments. Canadians were first. We presented our work on cavernous sinus, and the groups in California and Pittsburgh followed us. So we routinely will not shy away from opening it, but we'll also be realistic to what we can achieve. But we presented this paper in Istanbul, where Sylvia and Shireen were there a few years back. And we found even when the cavernous sinus was not involved by tumor structurally on the MRI, and we presented a series of 16 cases, we found that there was still tumor cells in the cavernous sinus wall in about 2 out of 3 patients. So the tumors that you saw on the MRI where it's humongous and everything, those kinds of tumors we're not going to cure by one single approach. But I think we can get much better control rates if we have the surgeons that are trained and properly able to safely remove that. If they're not able to safely remove it, you're going to put the patient's life at risk. Don't bother going there, okay? But if you can cure the patient with surgery and avoid expensive medications, it's worth doing. So I can't answer your specific question to one specific patient, but rather in general. I think you have to go to a surgeon who has expertise in that area and knows their way around that area and has the ability to deal with the tumors in that area, and also ability to deal with the complications if should they occur. But I think it's totally doable. We presented the work a long time ago. Others are now presenting their work, and more expertise is developing around the world. So it has to be assessed on a case-by-case basis, and we have to do that.
Dr. Ezzat?
Yeah, I just want to add one minor comment to that, and this is something that Dr. Cusimano and I can actually think about looking at later. We do know that the different kinds of tumors also have different qualities in terms of their texture. Some are soft and they're easy for him. Like, he could go in and clean out the cavernous sinus because it's a soft tumor that he can scrape out easily, whereas something like the immature PIT1 lineage tumors, they tend to be very fibrotic and sticky, and there's no way he could pull it out without ripping the artery that you need to keep intact, right? So again, remember, we're not talking about a single disease, we're talking about many different diseases, and each case has to be looked at from a different perspective individually because of all of these different factors that play a role in the ability to operate.
So on that, when you've got the 6 different kinds, how do you know the classification of your tumor? Because right before it was A or B, and now you're saying there's 6. So, right, so we had A or B, so now how do you get that answer?
Pathology. Some of it you can tell radiologically, but most of it's pathology.
Okay.
So
Traci?
then my question as a patient would be, if my surgeon says he doesn't want to operate, where do I find an expert?
Okay.
He's right there in the
Well, I think there are many excellent surgeons, and I think another thing that a group like this can advocate for, which is another advance that we didn't have way back a long time, and now we have a community of people who can speak together and can speak to other people. But I think we need to advocate for regional centers of excellence. We don't need 20 places. If you look at the data from the United States, and I bet the data from Canada is probably similar, but some of my colleagues at Harvard looked at the number of operations done per hospital. And it's really like an exponential curve. There are some that do over 100 a year, but the long tail, the vast majority of hospitals in the United States are doing 5 or fewer operations a year. And we know from all kinds of types of surgery, whether it's heart surgery, hip surgery, or brain surgery, that the more you do, the better you get at it. And you go away and you learn the techniques and you get the technology and whatever you need, and you develop a group of people like pathologists, like endocrinologists. Radiologists are critical. We haven't even said a word about them, but they're also critical to this, and another big advance that's happened. And so societies like this can advocate to say, okay, well, we need these centers of excellence. There's no point getting these centers that do 2 or 3 cases a year, because they're not going to go into the cavernous sinus. They're going to say, I'm okay, just I took out what I could, it's safe, now go on medication or go on radiation. Because that's what they honestly feel in their heart, they achieved what they could. But if we want to elevate the standard, I think one way to achieve that is with subspecialization and regionalization of care. And so this group could advocate for that type of thing. And in Canada, it's doable because the government basically is paying for it. There's one payer and one group that we need to speak to. It's not going to come from the doctors. Come to a certain extent from the doctors, but it has to come from the willingness, leadership of the provincial health systems and some coordination across the country.
So
And
that's where we need to collaborate.
yes, I think a big voice from the patients would be tremendous.
Because I know that this has come up in many discussions, that we do want pituitary of excellence in each province for pituitary diseases. We would love, as a patient, to show up at 8 o'clock in the morning, do our blood work, have our MRI done, do our ultrasound on our heart, blah, 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 then go for a coffee and let our endocrinologist get all that information given to her or him, and then go to our appointment an hour to 2 hours later. They've got up-to-date, detailed information, exactly what's going on in our whole body to even fine-tune our care even more.
And I have a question. Wouldn't it be great if we could take our doctor to our doctor's appointment?
That too.
Okay.
Our GPs.
Yes. We sit here and learn if I could go to my doctor's appointment and he's sitting there and I'm asking questions and he's asking questions, or he's sitting there at least taking in what I'm not hearing, because 9 times out of 10, 5 minutes in, that's it. I'm sitting there, Dr. Ezzat or whoever is speaking, and I've checked out. So if I could go back and ask my doctor, my family doctor, and he'll say, well, I don't know, you have to speak with your specialist. Like, well, I did that, but here I am. So is that an option at all?
And
could that be a thing?
Want to add to that, right? We want our nurses back. We want our endocrinology nurses back that are there when we go to our appointments, to talk to after we have our appointments with our endocrinologist, to answer the questions or give us guidance on what we need to do, where we got to go, because we know our endocrinologists are busy. We know they don't have 2 hours to sit with us. We get it. We know that. But we still need somewhere to go in between me and the endocrinologist. And I started this journey 10 years ago. I went to a meeting and there was, I don't know, 18 nurses at that meeting. We got 2 nurses left in Canada for endocrinology nurses, and that's back east. We need our nurses back.
I have to make a comment on that one. There's one nurse in this area only for one reason, and that's that a very wealthy patient said, you're not taking away my nurse, and he's paying for it. So that's how bad it is.
Well, yeah, but
one of the two.
It shouldn't be this way.
So that's a budget issue more than anything else.
Yeah, so just, those are all very good points. The reality is that the hospitals are strapped for money, and I'll speak from neurosurgical perspective. The pituitary tumor is only one tumor that patients have treated. So the same thing could be said for meningioma, for glioblastoma, for aneurysms that rupture, and it's true. So imagine those family doctors coming to every single one of those. So that's where there's efficiency in numbers. And that's why doing something like that, when the center may treat 5 or even 20 patients a year, will not be realistic unless you have some rich donor or someone to do that. So that's why there has to be regionalization. And frankly, some provinces in our country don't have sufficient numbers to justify efficiency of cost to reproduce what Dr. Ezzat does. I think there could be one pathology center in the whole country that looks at all the pathology things and does the detailed analysis that she does. And we have the willingness from every province to go pay for what it costs to do it. Doesn't make sense to repeat it in all the provinces. Why just have one, and with that expertise, we can move things forward. Okay? So I think there has to be efficiency of numbers. So some provinces might not have their own doctor or their own center of excellence, but things like the telehealth and things are ways to overcome that.
Okay. I think Dr. Ezzat wants to jump in. I see he raised his hand.
Connie had a question.
Yeah.
Just 3 very quick comments. The cavernous sinus invasion, guys, just to remind everybody, this is symptomatic of the fact that we are a decade behind the onset of disease. So let's get back on track. If we are to actually make a dent here, it is to identify the disease earlier. 2, I'd like to have it resolved that from this meeting that the registry is going to help put together forward some of the features that will allow for a better and earlier detection of acromegaly in Canada. What do I mean by that? I mean that if you're able to input the information of what's really happened to you, what can we learn to be able to give back to the medical community information, to be able to see that when you have A, B, and C get a hormone level or think of acromegaly, if we can resolve that the latency, the delay in diagnosis is going to go down from a decade to less than 5 years, I'm going to be a lot happier. Number 3, no orphan can ever survive in any disease until they find a family that will adopt them. What do I mean by that? It means that acromegaly as a form of pituitary disease has to have some opportunity to allow them to get into the system of whatever that medical community is, whether it's a hospital or in a privatized system. I'm going to remind you, Michelle, the reason why in British Columbia somatostatin analogs are delivered to patients is because it comes from a cancer agency, because they see some semblance. That's what I mean by adoption. You have to be under an umbrella. And one of the things that I am so incredibly dedicated to is related, and it's based on scientific evidence that we have developed. The work for the WHO is ultimately to help people find these homes, these families that will adopt them, to be able to allow them to gain access. Nobody's going to be able to survive with, Michael, with all due respect, even if you were to increase the number from 5 to 100, every hospital is going to come back and tell you it's only 100 patients. Come on. There has to be an infrastructure that allows for a seamless integration, that allows for the pituitary to find a home, a natural home that fits and allows for the benefits to be able to get access to those patients. I rest my case.
Thank you. I know Connie was waiting for to put her question forward. So Connie, go for it.
I'm good. Yeah, the last time I tried that, I just about took everybody out. First of all, I just want to say thank you very much to all the doctors who have shown an interest in even helping us deal with this on a regular basis at conferences like this. This is amazing to me. Where else can you sit at a table with a medical specialist and talk about your grandchildren or other things than just, at an event like this? This makes it so personable, and I just want to say thank you to you all, because you make us feel like we're actually important. And I think that is where a lot of times doctors misinterpret our concerns and all of that. And I'm not, the doctors that are here do not fit into that. You have all been very supportive and understanding. But I want to switch my question to something else. I did want to say thank you, because I love you all, and you're all so wonderful about your participation. And without you, we wouldn't even have the conferences like this. It would be all questions about how to make it better. And you are helping us make that better. But I have a question for Dr. Ezzat, because I was really impressed with the fact that there are more than one type of tumor. I was because for so many years, we've all just thought it was just the one tumor. And I was wondering, is the size of the tumor, or does it make a difference in the symptoms? Or like you also mentioned that, if you have more than one tumor, because I had a benign thing removed from my left thyroid and removed that, as well as a very small pituitary tumor that wasn't diagnosed until I was almost 56. So I'm just wondering, are symptoms different for the size of the tumor or the number of tumors that you might have throughout your endosystem?
Absolutely. The tumors are all really different in terms of their behavior, both in terms of hormone secretion and growth patterns. So there are some tumors that tend to be small, but very secretory. And there are some tumors that can be huge and infiltrative, and you barely can know the patient has acromegaly until you measure their IGF-1s. So, of those 6 different types, there are combinations. They also grow differently. As I said, some of them are hard and some are soft. We can see a little bit of it on MRIs beforehand, so we can get an idea that it's in one group or another. Are they densely or sparsely granulated? They have different genetic changes. Some of them are more commonly hereditary, some are not. All of these are different components that make us recognize that there are different diseases. They all have acromegaly, but they're all different diseases. And I'll make a comparison with something else that many of you probably are more familiar with. In the early 1980s, we used to talk about breast cancer. Breast cancer was breast cancer, and we treated every woman the same way. Today, I'm sure any of you who knows anybody who had breast cancer, you have to know, is it ER/PR positive, is it HER2 positive, and we treat them all differently. It's exactly the same thing with acromegaly. We have to get to the stage where acromegaly isn't good enough. A pathologist or a clinician who treats a patient for breast cancer today would be sued for malpractice. It's not breast cancer. What kind of cancer? Is it, triple negative is a different disease from, all of these things. We talk about this as routine now. In acromegaly, we're not at that routine level yet, but we're getting there because we're starting to understand it.
Thank you. Any other questions? Are we about to wrap up? Yes, because it's 4:30 and we've been talking for about an hour. So on that note, I always ask the panelists for sort of a parting shot or a final comment or something to give us to think about. Bradley, unfortunately, you're number one.
I really don't know what to say. I think that being able to come together as a group in a community like this is going to be so beneficial for everyone, for doctors, for patients, for family, for caregivers, just to be able to kind of come together and bond and be able to kind of have that moment of, these people understand. And I think it's only going to get bigger and better in the future, knowing that we're trying to get these things diagnosed earlier and sooner, and be able to bring people into this kind of community. So I just look forward to that, and I think overall that this is great.
Awesome. Traci.
Well, I'm going to echo that. I always learn so much from all of you, not just the clinicians, but also from my fellow acromegaly sufferers. So just thank you. I appreciate all of this, and this, I don't know where I'd be without this community.
Michelle.
Thanks. It was nice that Connie said thank you to us, and I'm sure all the clinicians would agree that we want to say thank you to you, that you've taken a lot of extra time and energy to form this group and organize meetings like this and be proactive, and you're actually, of course, helping yourselves, but you're really helping us, and I think I just want you to know how powerful your voice is and should be and could be even more. And when we're talking about, we'd like to get some of it at an earlier stage, we'd like to have more nurses that would help both of us out. I think your lobbying is more powerful than ours in many ways to get some of these resources. So it's great that we're working together, and it's going to help us all.
Very good. Dr. Ezzat?
Well, like Dr. Johnson, I want to thank you all as well. I think it's really important that groups like this exist and that you guys keep up the communication. And as she said, we only get stronger together. So let's keep working on it.
Good. Dr. Ezzat, it's late, getting late in Toronto, so I'll let you say a few words.
No.
You may want to go to dinner or...
Dr. Johnson said it very well, so I'm going to echo. I'm not going to repeat it, but thank you guys for giving me the opportunity to be able to join you this afternoon. I always learn something, obviously, and I really hope that the registry will, in fact, take off, and let's try and get the word out. Doesn't have to be, this is not in any way related to you, me, or the center. This has to do with everybody around the country, so we can, hopefully, the next time that we meet, we'll build on this, have something tangible, so we can deliver in a meaningful way that's going to have a positive impact. Thank you very much.
Thank you. Dr. Cusimano, the final words for today.
Well, I want to thank you for allowing me to be here, but I also want to say that The road often looks bumpy and dark and stormy, and you often feel alone, but there's great optimism for hope always. You have peers and you have professionals here who care and who want to make the future better, and we're always there for you.
Great. Well, let's give them all a warm applause.